I'd like to welcome, the topic today for our last presentation is biomarkers by Dr. Farrand. Dr. Farrand is a scientist on the Michael J. Fox Foundation Transitional Discovery Research Team. She helps manage project portfolios around early therapeutic development and fluid biomarkers in areas related to inflammation and symptomatology. Dr. Farrand is a PhD neuroscientist by training and spent several years in academia focused on research related to processes contributing to degeneration in Parkinson's disease and how to combat those with new stimulation therapies. She aims to contribute to Michael J. Fox Foundation's mission of improving treatments and ultimately finding a cure for Parkinson's disease. Welcome, Dr. Farrand.
Thank you so much. I'm so excited to be here. Let me just make sure I can share my screen. Okay, can everybody view the slides okay?
Looks good.
Okay, excellent. So thank you so much. Like I said, I'm so excited to be here. A lot of times I talk to scientists all day, and so I really appreciate the opportunity to get to talk with patients instead and their families. So as Charlene said, I'll be presenting on the biomarker strategy that the Michael J. Fox Foundation has put together and some of the recent advances we've made in this space. I'm sure this will be a review for most people, but I'm going to start with just some basic facts about Parkinson's disease, and then go into an introduction to the Michael J. Fox Foundation itself for anyone who may not be familiar. Then move into our overall biomarker strategy, and then I'll highlight the synuclein seed amplification assay, which I know was mentioned in the previous presentation. So what is Parkinson's disease? We know that it's the second most common neurodegenerative disease behind Alzheimer's, and it affects 1 million people in the US with 6 million cases worldwide that we know of. And this is only diagnosed cases, so the actual numbers are probably significantly higher than this. We also know that only 10% of cases can be currently attributed to genetic causes. So we know that genetic mutations may increase your risk for developing Parkinson's, but many people also have these genetic risk factors but never go on to actually develop Parkinson's disease. We also know that advanced age, environmental toxins, and head trauma can increase the risk of developing Parkinson's. And we also know that this is primarily a movement disorder, but that there are also non-motor symptoms involved, namely REM sleep behavior disorder, constipation, and loss of sense of smell can occur sometimes years prior to development of those motor symptoms. And that motor symptomology usually begins with a unilateral tremor that eventually progresses to both sides, and other accompanying motor dysfunction, such as stiffness in limbs, maybe feet feeling stuck to the floor, a stooping posture, and then in later stages, patients can also develop cognitive symptoms. So we know what it looks like in clinical presentation, but what does Parkinson's disease look like in the brain? So in general, Parkinson's is defined by the following criteria. So there are loss of brain cells in the substantia nigra, which is the brain region that you can see in the top image on the right-hand side of the screen here. So on the right-hand side, you have what would be a normal, healthy control patient. And you see these black bands kind of towards the bottom of that brain section. And this is indicative of healthy cells in the substantia nigra. These cells produce a substance called neuromelanin, which gives it that coloration that you can see, the darkness that you can see. And then on the left-hand side, we see a similar brain section from a Parkinson's disease patient. And so you can see that there may still be some coloration there, but that's very much diminished. And this is visible to the naked eye. You don't need to do any staining or look under a microscope or anything like that. And then we also know that there is a Lewy body pathology in those neurons that do actually survive in the nigra. These Lewy bodies are composed of a protein called alpha-synuclein primarily. And that's something that I will definitely touch on later when I talk about the seeding amplification assay. And in the middle pictures here, you can see when we do actually stain that brain region and look under a microscope, you see all of these purple looking cells. And so these are normal cells that appear in the substantia nigra. And then in the substantia nigra from a Parkinson's patient in this middle image, you can see that these cells are no longer present, indicating that they have died. And then on the far right-hand side, you can see the Lewy bodies that show up in the remaining cells of these Parkinson's patients. And so you see the dark substance, this brown looking color here is actually the neuromelanin in that cell. So we know that we're in the substantia nigra because you can see the neuromelanin. And then this purple inclusion that looks to be a very solid mass in the middle of that cell is actually a Lewy body. And then as we've advanced research over the last several decades, we do have some biomarkers that are starting to come up that are enabling improved diagnoses. So one of these being DAT scan, which is an imaging technique shown at the bottom here, where we can actually see the dopamine cells in the brain. And so on the left-hand side here, you see a DAT scan from a healthy patient. So this one has very substantial activation that's showing up here in the substantia nigra. And then on the right-hand side, you see a DAT scan of a patient with Parkinson's disease, where you can see that the dopamine in this region is not nearly as activated as it is in the healthy patient. And then, as I mentioned, there's also a spinal fluid test that has come out really this year, is when we have made it more public to measure alpha-synuclein clumps. And so Parkinson's disease is treated in several ways. It's important to note, though, that currently we only have treatments that can target the symptoms of Parkinson's disease. There are no therapies currently available that slow or stop the disease progression. So primarily levodopa and carbidopa is the most prescribed drug for PD, and this helps replace the dopamine that's lost when those brain cells die. The primary surgical intervention is deep brain stimulation. There are some limitations as to who may qualify for deep brain stimulation, and this works through an electrode that's implanted into the brain that helps mediate that electrical signaling to regulate the stiffness and slowness of movement that Parkinson's patients often have. And then in terms of non-motor symptom relief, this is often medication that targets either depression or dementia, sometimes even hallucinations or pain. But it's important to note for these that these medications are not necessarily Parkinson's specific. And so there's a lot of room for improvement in terms of whether medications may be able to target these symptoms in Parkinson's patients better than what is currently on the market. And then we also know that diet and exercise are very beneficial for Parkinson's patients. So now just to go into a little bit about the Michael J. Fox Foundation. So our overall mission is that we're dedicated to finding a cure for Parkinson's disease. We do this through an aggressively funded research agenda, and we're also committed to ensuring development of improved therapies for those that are currently living with Parkinson's today. So the Fox Foundation is a public charity that was founded in the year 2000. We are currently the world's largest funder of strictly Parkinson's research. We're a team of over 215 individuals, primarily based in New York City, but we do have fully remote employees such as myself that live in other parts of the US. And we had more than 165,000 donors that supported our mission in 2022. To date, we have funded more than $1.5 billion in research programs made up of over 4,000 research projects. And specifically, over $250 million of that has been spent on biomarker research to date. We annually review about 1,000 applications and fund about 350 projects on a yearly basis, and 31% of those funded projects are led by researchers outside the US. So we are not restricted to only US-based research. We fund companies and academic institutions all over the world. So these are some of our guiding principles that we try and keep at the forefront of our mind on a daily basis when we're formulating our strategy. So we always like to keep people-centered research at the very forefront. So we want to make sure that all of our efforts link to outcomes that matter to people with Parkinson's disease. We want to make sure that everything that we develop and that we help advance is going to be may really make a difference in patients' lives and their families' lives. We also support diversity, equity, and inclusion in all of our efforts. We seek to address determinants behind DEI challenges. And one of the ways that we do this is by supporting diverse clinical trials. And some of you may have seen earlier this year, we had a publication come out through our GP2 program that identified a novel risk factor in people of African descent specifically. So that's very exciting. And then we are also very committed to open science and reproducibility to really help accelerate our progress. And then we also have resource leveraging to really enhance success across the field. So our programs often default to the use of existing data, samples, and resources whenever possible, as opposed to going out and trying to always collect new samples when there may already be samples available. We also want to make sure that we are considering external input to really validate and guide our thinking. So we do this through external advisors, including actual patients with Parkinson's disease. We have a patient advisory council that meets a couple of times a year. And we get to present our progress to them and make sure that all of the things that we're doing are relevant to those patients and their families. And then we also definitely recognize that partnerships amplify impact. So we bring together like-minded stakeholders to the table, whether MJFF is a leader in those efforts or simply a contributor. In general, our funding philosophy kind of falls into this middle realm of research advancement. So very early stages of research, you may see as early discovery, where people are trying to identify new protein targets that may be relevant for patients with Parkinson's disease. And then once you identify that, yes, this is a relevant target for Parkinson's, then we move into really validating that target. And then once that target is validated, we think about how to target it therapeutically, how to translate it into something that would be relevant for patients. And then we move into clinical development, phase 1, 2, and 3. But the Fox Foundation's funding efforts really focus in that middle section from target validation up through phase 2 clinical trials. And so we focus on this the middle translational spectrum to de-risk the field for larger funders and to promote a multiple shots on goal approach. So our strategy centers around the following programs and cross-cutting principles. And the ways that we do this, we attempt to address field-wide challenges by aligning the field around what the research priorities are that we've identified. We also sometimes invest in riskier projects that may be considered too risky for a larger company. And then we also support concurrent biomarker development with our therapeutic efforts. So since opening its doors in 2000, the Fox Foundation has had a huge impact on the Parkinson's disease research and therapeutic landscape. We've done this in several ways. So there are more clinical studies happening right now than ever before, focusing on a very diverse set of targets. And we funded some of those early studies that have now led into clinical trials. So in terms of improved treatments, we have helped fund projects that created new formulations of existing drugs, and those drugs have helped patients better manage their symptoms. In terms of biomarker breakthroughs, some of the early DAT scan validation studies were funded by the Fox Foundation, and this was validated as an early PD progression marker. And now we see the synuclein seeding amplification assay that's really starting to provide a biological basis for disease diagnosis in patients, whereas previously it's been strictly clinical-based diagnosis. And then we're also getting closer to developing a brain scan to be able to visualize clumped alpha-synuclein in the brain. This would provide a non-invasive biomarker, which would be a huge breakthrough. And so we awarded a $10 million competition award this year for a company developing a alpha-synuclein-based PET scan. And then we have also helped advance biology. And so one of the major ways that we do this is through partnerships with organizations like Aligning Science Across Parkinson's, or ASAP, to really partner with groups that are on the forefront of the discovery research base and trying to identify new targets that we can then feed into this therapeutic development pipeline. So in 2023, there have been 2 major research breakthroughs so far. One, like I mentioned, is the PET scan related to visualizing alpha-synuclein in the brain. So Merck was announced as the winner of this imaging competition for advancing the tracer to visualize alpha-synuclein. And the first in human clinical trial of this tracer is set to begin this year. So we're very excited about that because, like I said, this tracer would be enable a biological based diagnosis and monitoring in living patients in a non-invasive way. And then the second thing being the synuclein seeding amplification assay that we know can detect abnormal clumps of synuclein that form in these Lewy bodies that we see in Parkinson's patients. And so we did a validation study in the Parkinson Progression Markers Initiative, or PPMI, which is one of our huge landmark historical, or it's a what is the word I'm looking for? Natural research study where we collect samples from patients over time. And so in using these samples, we've seen that with the synuclein seeding amplification assay, there's a 93% accuracy in identifying which individuals have Parkinson's or are at risk for developing Parkinson's disease in the near future. So providing, again, an accurate biologically based diagnosis in living patients. And we hope that this will also enable treatment accuracy and better clinical progression. So how do biomarkers play into our overall research vision? So we have a people-centered understanding of PD as our research vision, and that this would then fuel a diverse therapeutic pipeline of de-risk biological targets, measurements, and therapies. And then with our mission, we support a robust portfolio of programs that defines and supports translational roadmaps for integrating biology, therapeutic, and measurement insight. And so we kind of divide our funding programs up into 3 different areas: defining PD, measuring PD, and treating PD. And so the biomarkers really falls into that middle piece, that measuring PD. Whether that be at very early stages, establishing risk screening methods, or at later stages, establishing measures linked to meaningful quality of life improvement. And so when we think about our overall biomarker strategy, biomarkers is really just a fancy thing to say these are biological characteristics that help us identify risk, onset, or progression of disease. These are often in fluids like cerebrospinal fluid or blood, but they can also be imaging, digital biomarkers, things along those lines. But better biomarkers would ultimately help with earlier diagnosis and therapeutic intervention, charting disease progression, better designing of clinical trials, and as well as evaluating the impact of new therapies. And so researchers are investigating ways to measure Parkinson's with brain scans, fluid, and tissue samples, among other methods like the digital biomarkers that I mentioned. Our overall biomarker goals, we really see as spanning the entirety of the therapeutic development pipeline. So if we think about some ways that biomarker strategies can feed into that early target discovery and validation, so we can leverage existing data for disease subtyping that would help inform which patients better qualify for clinical trials. We can also determine which early biomarker studies need further validation using larger, well-characterized clinical cohorts such as PPMI. And moving into the translation to therapeutic development phases, we can try and integrate the biomarker development with the therapeutic development so that we know when a therapy is moved into a clinical trial that there is a concurrent biomarker that can measure the efficacy of that therapy in a biological way. We can also identify key gaps to support ongoing and planned clinical trials for high priority targets, and then developing strategies to support novel targets. And then when we start to move into the early clinical therapeutic development phases, we really want to make sure that we're helping develop a plan that would allow dissemination and analysis of biomarker data from those clinical trials for the larger public. So we have several components that we see as supporting our biomarker strategy. These fall into 4 major categories: landscape analysis, including our pipeline report, which we publish hopefully on an annual basis. So we're at version 2 right now, and we do plan to update that annually. But this shows what biomarkers we're looking at, where they are in the development pipeline, and how close they are to being able to be used for clinical assessment, as well as investment across the pipeline. So we fund biomarker studies at all stages of development. And then we also help provide and collect and provide biosamples for research. And we do this by standardizing the way that these samples are collected across the sites so that we can be sure that those samples are comparable. And then we also help make sure that these samples are widely available to the research community. In terms of collaboration, we put together both workshops and consortia to help address field-wide challenges. And we have weekly teleconferences for researchers on PD priority targets, where they can come together and discuss the newest research that's coming out, and really what we do with those research findings. So what are the next steps to really help make sure that we're advancing therapies as quickly as possible. And in terms of data, we require sharing to encourage our open science across the research landscape. And we also want to make sure that researchers are able to access that data so that we can then drive increased analysis and data mining to help accelerate new discoveries in the space. There are still several challenges related to biomarker development, though. This is a long road from early discovery and development stages to actual implementation. And we are working to address those challenges as best we can. So one of the major challenges, of course, is what to measure and where. So should we be looking in imaging in the brain? Should we be looking in the blood? And how do we identify what the best targets are? So the way that we approach that is really staggering investments across the pipeline. So we fund very early discovery biomarker projects, such as projects involving digital watch data, discovery as to whether or not we can detect things like alpha-synuclein in tears, as well as brain imaging, and then all the way up to validation of things like DAT scan and the seeding amplification assay. Another major challenge that we face is lack of assay replication and validation across the field. So one way that we address that, we fund some of these efforts in head-to-head studies and forming pre-competitive consortia around a common goal. And synuclein is an area that we have done this. So we had a consortium that we put together for synuclein that combined major academic groups as well as several major companies, and really looked at different ways to measure synuclein, whether it be in the blood or through imaging, and really comparing across those ways of analysis to see if everything lines up across the board, basically. And so we do help foster those collaborations among both academics and industry scientists. And we know that these scientists are willing to work together to address these key questions, particularly around biomarkers. The next major challenge we faced is limited access to high quality clinical samples. And so one of the ways that we're addressing this is, so we have several patient sample cohorts that are available for researchers. So since 2009, the Fox Foundation has collected, banked, and distributed critical patient samples for PD research using standardized operating procedures across these collections. So you can take samples collected in California and samples collected in New York City, and you can be confident that they were collected in the same way so that they can, those results can be compared directly from those two different sites. So across these different studies, we have 14 different types of samples, from DNA and RNA isolated from cells to cerebrospinal fluid to blood to saliva and urine. And we also have some skin sampling as well. And to date, we've received more than 650 sample requests from researchers for these studies. So these samples are being very well utilized by the research community. And then this final challenge here is that there's a lot of data generated from some of these sample analyses. So what can we do with it? How can we maximize the use of that data? And we do this through data sharing and regulatory endorsement efforts. So we help fund efforts to generate and harmonize large data sets so that multiple researchers can access them and be able to interpret that data in a meaningful way. We also require that all of our grantees publish their data in what we call an open access forum. So you don't have to pay to be able to read those research papers. They are publicly available. And then we also can help advise on regulatory pathways for treatments that are advancing to clinical stages. And as part of our landscape analysis, we put together what we call the Parkinson's Biomarkers Pipeline Report. So there are 4 different stages of biomarker development. So starting in early discovery and development through optimization of the assay. And this specifically relates to biomarkers in fluids, so blood, CSF, and things of that nature. Once that assay has been optimized, then it moves into what we call a validation phase, where we look to see if the assay is able to distinguish accurately who has Parkinson's versus who doesn't. And then that advances from there to a clinical qualification stage where we look in a very large cohort and make sure that the assay is able to scale up to that level that we would need it in a clinical setting. There are also lots of different types of biomarkers. So a lot of times when we think of a biomarker, it's, does this patient have Parkinson's disease or not? That's a diagnostic biomarker. But there are also other relevant categories. So things like prognostic biomarkers, where we may be able to use a marker to determine if a patient is more likely to develop cognitive symptoms later in their disease course. Things like pharmacodynamic biomarkers that are able to measure how well a patient responds to a treatment in a clinical trial and things of that nature. So these are all categories that we track in this pipeline report. So these are just some summary figures from our most recent version of the report. So on the left-hand side, you can see which biomarkers we have reported that fall into those 4 development categories that I mentioned. So most of these studies are still ongoing. And you'll also notice that we have some biomarkers that are categorized as complete, meaning that they did not pass that validation stage and did not move on to the next stage. So while there's a lot of active research going on, it's not always successful, unfortunately. But that being said, there are times where it is successful, and those are huge accomplishments that should be celebrated for sure. And then on the right-hand side, so we have how many biomarkers in the report are being conducted in studies in different samples. So primarily, we see CSF and blood. So blood encompasses plasma as well as serum, and other blood products as well, like platelets and whole blood. And then, and all of these have helped inform how we think about how we diagnose Parkinson's disease, right? So the biomarker space is really starting to shift in a way that we can start to think about how to diagnose Parkinson's in a biological way versus a clinical, strictly a clinical assessment. So historically, Parkinson's has to be diagnosed through clinical outcomes only. So some of you may have seen a figure similar to this at the top, where you may have symptoms I mentioned, like constipation or REM sleep behavior disorder, or RBD, much earlier than the onset of those motor symptoms. But Parkinson's really can't be diagnosed until those motor symptoms appear. And it's important to know that when those motor symptoms do show up, there's already been a significant loss of neurons in the brain. And so if we can diagnose Parkinson's earlier, we can help prevent the loss of those cells before those motor symptoms start to develop. And so where we are today, we have whole genome sequencing to help determine people that may be at risk, have some of those genetic risk factors for developing Parkinson's later in life. We also have the synuclein seeding amplification assay that allows us to detect in cerebrospinal fluid whether there's clumped alpha-synuclein or not. And then we also have the dopamine transporter, or the DAT imaging. And so this can help track when PD may start to show up symptomatically, and then it also allows us to track progression. And so in future years, what we hope to do is incorporate markers of other pathways that we know are relevant to Parkinson's disease, such as immune function, or mitochondrial function, or protein aggregation biomarkers, to help better delineate that progression that occurs in Parkinson's patients. And so here I'm just showing that we do in fact have biomarkers in our pipeline report that we're tracking across some of these pathways. LRRK2 is a known risk factor for Parkinson's disease that relates to the ability of the cells to clear alpha-synuclein. And so that is a major area of focus. We also have quite a few markers in our pipeline report related to inflammation and mitochondria. And so now I wanted to talk just a little bit more about the seed amplification assay, because it has been such a huge area of focus over the last year. So when we first started talking about how to put together this biological staging framework, the first question that came up is, are we ready for this? Like, is this something that the field is really ready for? And of course, the answer is yes. Yeah, we're overdue for this. We've seen the Alzheimer's field do this, and this biological staging. And so that's something that I think we are well due for in the Parkinson's space as well. And so this figure is just showing all of these different pathway markers that I mentioned before that could potentially feed into the staging system as we learn more about the pathway biomarkers. We know that alpha-synuclein plays a huge role in PD. It's, like I said, is the major component of the Lewy bodies that develop in the brains of Parkinson's patients. And this was first described in 1912. So there was a scientist who described something that he saw these clumps of protein occurring in the brain in several specific brain regions, one of them being the nigra. But once we were able to get that brain stained and under a microscope in later years, that's when we were really able to visualize those Lewy bodies. And in some cases, there's a theory of how Parkinson's disease progresses. And so that's what I'm showing at the bottom here, that Lewy bodies may start in the lower brainstem, and as the disease progresses, these Lewy bodies that were first only expressed in these lower brainstem regions, they start to spread to the rest of the brain. And so once they start to spread to the middle of the brain, that's where you start to see those motor symptoms show up. And then as it advances even further, you start to see much more widespread expression of Lewy bodies in the brain. And that's where you may see some of those cognitive symptoms start to show up in later disease stages. So what is the seed amplification assay? How does it work? This is a bit of a complex slide, but I hope that I can break it down and be able to explain it well. But we take fluid, so right now it's cerebrospinal fluid, and we're able to isolate synuclein from that fluid. And then we put it through this assay to initiate the aggregation of the synuclein. And so if the synuclein that's been isolated from the fluid is prone to aggregation, then we'll see it start to aggregate as it goes through this assay. And when we look at the data of the samples that we've run, we do in fact see that the Parkinson's patients have much more of this clumped aggregated alpha-synuclein than healthy controls, and even more than MSA patients, which is another disease in which alpha-synuclein plays a role. So key findings from studies related to this assay so far, we know that there's a very high diagnostic accuracy for sporadic PD versus healthy control patients. Numbers up to 85 to 95% sensitivity, which is the ability to accurately diagnose someone who does have Parkinson's disease, as well as a 93 to 100% specificity, which is the ability to accurately determine who does not have Parkinson's disease. And these numbers are consistent irrespective of which version of the assay we use or who runs it. So it doesn't matter whose lab it's run in either. These numbers are consistent across the spectrum. And just for reference, generally about an 80% sensitivity and specificity is considered a good biomarker. So this is significantly better than what we would consider a good biomarker in the normal clinical space. We do know that patients with LRRK2 PD, so LRRK2 is one of those genetic risk factors that I mentioned before, tend to behave a little bit differently. So there may be more variability in rates of whether a patient with LRRK2 PD is SAA positive or not. And then there was one case actually of LRRK2 PD where the negative synuclein amplification assay, we were able to confirm in brain samples from that patient that they actually did not have Lewy pathology in their brain. So there's something different about LRRK2, this type of PD, that we don't really fully understand yet. There's also, we know that SAA can inform PD staging. So when the SAA is negative, we see that it's negative in the vast majority of non-manifesting carriers. So patients that have these risk factors but don't yet have Parkinson's disease do not have SAA positivity. And that suggests that the presence of synuclein aggregates in cerebrospinal fluid is not a lifelong trait, but that it's acquired at some point relatively close to disease onset, which is an important point. And then we also know that SAA results can be positive in prodromal Parkinson's patients. So maybe patients that don't yet have abnormal DAT scans, but do have things like REM sleep behavior disorder or olfactory dysfunction and things like that. So it seems that SAA can potentially be a very early indicator of synucleinopathy. This is just a timeline of what the MJFF investments in the SAA have looked like. So we actually started this work way back in 2014. So that gives you a little bit of an idea of how long it takes from when this assay development starts versus when we can start to publicize it. So we first started the development in 2014. Then it moved into the analytical validation phase about 4 years after that. And then quickly moved into the clinical validation phases in larger patient cohorts. And then we worked to improve on the assay. So optimizing, scaling, and quantifying these assays across matrices. And then we've also formed a consortium based on the groups that were working on this assay. And we're also currently expanding to other tissues. So not just cerebrospinal fluid, but other tissue or other fluids and tissues that are easier to access. And then in 2022, this was deployed across our PPMI patient cohort. And so all of the CSF samples that we had in this cohort got SAA testing done. And so this was introduced as part of the PD biological staging framework that was introduced earlier this year. And so we really see this, this SAA assay as a key component of a flow chart of the current biomarkers that we have available. So this is really a strategy to identify these SAA positive individuals at a very early stage of degeneration that could hopefully then lead to earlier interventions in the future. So very early on, an individual may have genetic testing done. And so if it shows that they have a genetic risk factor for Parkinson's, they may then be referred for SAA testing. And if that SAA is then positive, then they may be referred for a DAT scan. And really, when that DAT scan becomes abnormal is really when you start to see this clinical manifestation of PD. So it's a lot of technical, how does SAA work, but what does all of this mean? So currently the impact is that we can see better characterization of PD biology and staging. This will enable better clinical trial design. SAA can be factored in as an enrollment criteria for clinical trials. And then we also see differential diagnosis of PD versus MSA, as well as disease subtyping for like the LRRK2 PD that I mentioned before. It's potentially enabling for prevention interventions later down the line. And then it could also be used as a novel marker of efficacy in therapeutic trials. What this may mean for the future. So this would be an objective marker for target engagement and therapeutic efficacy. It would enable better understanding of the continuum of PD progression as well as disease subtyping. It could be used as a potential screening test to identify individuals with high risk to develop PD in the general population, which would again enable earlier intervention, like I mentioned before. And it could also potentially enable personalized intervention much later down the line. So this is a huge breakthrough, but there are still unmet needs in the area of SAA. So right now, we only can tell from SAA whether it's positive or negative. So being able to quantify how much alpha-synuclein is aggregating in a sample may be able to tell us, that would be more informative for things like clinical trials where you can say that the aggregated synuclein decreased by 30% or by 40%. That would be indicative of how well the treatment is working. Less invasive matrices is also something that we are very much invested in. We know that it works very well in cerebrospinal fluid, but how does it work in blood? How does it work in saliva or even in skin biopsy samples? We're also looking at generating additional data around what we know about the CSF alpha-synuclein assay and what more we can learn from the CSF data that we already have. And then we also want to improve biological understanding. So is there a specific type of synuclein that's being detected in this assay that may be more indicative of developing later Parkinson's disease than some other types of alpha-synuclein? And so what we really hope in the next few years that we can really continue the momentum that we have built with these major discoveries in 2023. So with this nuclein seeding amplification assay, we didn't have any tests available to detect this pathology in living patients. However, now we do. So in the expansion of that assay to other peripheral samples like blood, so this would potentially generate an accessible, minimally invasive biomarker for synucleinopathies that could really help improve diagnosis. And relating to the biological definition of Parkinson's disease, through the advancements that we've made this year, we also want to add to that by uncovering additional biomarkers, validating assays in large patient cohorts like PPMI. And this would really lead to a much better biological definition of PD by revising what we already know. And then relating to therapeutics, we have a large number of clinical trials that launched in 2022, and over a quarter of these trials target disease progression rather than just treating symptoms. And so we're hoping that as we move through these clinical trials, as we add more biological biomarkers to the pipeline, that we can really start to think about this precision medicine-based approach to Parkinson's disease with therapies that could slow or hopefully even halt the progression of the disease. And so I hope you can see that we've come a long way from where we started back in 2000, but there's definitely still a long way to go in finding a cure for Parkinson's. And so we plan to continue this mission through redefining the Parkinson's biology by funding diverse programs to enable this multiple shots on goal type of approach, by building collaborations to tackle difficult research questions and priorities, because we know that no one person or group can do it all, by promoting open science to make those results widely available to the research community, by promoting diversity, equity, and inclusion to ensure that our priorities reflect the patient community we seek to serve. We also help train doctors to become movement disorder specialists to really help provide the best standard of care we possibly can for patients. And we also engage patients regularly to better understand the most pressing needs of those patients and to uncover new markers of disease. We also help advocate for change by working with government officials to ensure that the government is aligned with our mission and provides patients with coverage for medical care. And with that, I will take any questions. Thank you so much for letting me be here. This has been really great.
Thank you very much, Dr. Farrand. That was awesome. I do have a few questions that have come in. Is a DAT scan the same as a PET scan?
No, they are technically different. And I am not an imaging expert. I will just say that up front. However, different types of imaging can be better for different things. So a PET scan is generally considered as more accessible and easier to use. So if we could get a synuclein PET scan, that would potentially be better than even a DAT scan, if that makes sense.
Can patients in Canada be part of these data samples? And if so, how can they get involved?
Yes, absolutely. So the PPMI study that I mentioned is on our website, and we take patients from all over the world. It's an online based research study first. And then based on answers to that online study, they then select patients to potentially come in for sample collection. And so I'm actually part of the online version of PPMI. So you have a series of surveys that you answer questions every 6 months, I believe is the timeline. And so that's a really great way. The other way is Fox Trial Finder, which is also available on our website. And that can help you find research studies that are close to your location. So we try to help incorporate research studies from all over the world rather than just in the US. And so you can find research studies close to you that you may be able to participate in.
Have they expanded PPMI into Canada?
Yes. As far as I know, it has been expanded, yes.
Okay. What can you say about the future of immunotherapy and the role of vaccines?
Yeah, so we are funding an effort to develop a vaccine against alpha-synuclein. So that is still in very early clinical trials right now, but the hope is that, if we can better identify how synuclein aggregates in the blood, that we could then create an antibody against that process of aggregation so that someone could potentially get a vaccine to prevent future development of Parkinson's.
There's a question, can you talk about induced purulent stem cells, pardon me, and regeneration of nerve cells?
Oh goodness. So these are efforts that we're still funding actively. The difficulty seems to come in where we think about how to prevent the new cells that we put into the brain from also dying, because when we put those stem cell grafts into the brain, you are replacing what's been lost, but you're not necessarily stopping the process that caused that loss in the first place. And so that's really the biggest roadblock that we're seeing in that space right now. But we are still actively funding research in that area to try and better understand how to address those roadblocks.
This one says, just to confirm, there is not evidence yet that alpha-syn seeding assay provides quantitative measurement, only qualitative.
So we have some data supporting that the potential is there. We do not have validated data yet to be able to say that this can definitely be used in clinical trials for quantification.
Can you mention the efficacy of focused ultrasound treatment for Parkinson's disease?
So this is not my area of expertise. I sit primarily in the preclinical space. So I know that focused ultrasound can potentially be effective to help improve the rate in which we can get medications into the brain. But as far as like anything further than that, I'm not sure I would be able to comment on.